getting back into it, what is a liquid biopsy? So at its most basic, liquid biopsy is the analysis of any bodily fluids, be that saliva, blood, urine, sputum, stool, among others, for analytes of relevance to a patient's underlying malignancy. And those analytes can consist of circulating tumor cells, which we saw reported by Dr. Ashworth previously, as well as other metabolites, extracellular vesicles, cell-free DNA, proteins associated with the malignancy, antibodies against the tumor-associated antigens, micro and circular RNA, as well as epigenetic changes such as DNA methylation, and what we'll spend the majority of our time talking about today, which is circulating tumor DNA, which is currently the hottest of these analytes and the most closely studied. Now, an important question we might have is, well, why would we do a liquid biopsy? Aren't regular biopsies that we've been doing for the past decades good enough? So one of the main benefits of a liquid biopsy is that we have patients where we can't get a normal biopsy, be it through endobronchoscopy or CT-guided needle biopsy. Some patients have medical comorbidities, such as emphysema, like we see here, prior history of having pneumothoraces, or other conditions such as pulmonary hypertension, significant cardiac disease that preclude them from being eligible for a biopsy. And some patients refuse to have a biopsy, and it's not something they're interested in. Additionally, sometimes the tumor itself is in a location that's not particularly amenable for biopsy, such as right beside some important vessels or down near the diaphragm, where it's a little bit more challenging to actually get a good biopsy. In addition to being able to get some information about these tumors we wouldn't be able to have other ways, liquid biopsies are non-invasive, which allows us to have more frequent sampling at different time points without having a patient undergo potentially invasive procedures. And additionally, due to the nature of the systemic circulation of these analytes, it allows for some analysis of tumor heterogeneity, where there can be different subclones of tumor cells in either the primary or in distant metastatic disease, which may not be adequately assessed by biopsying only one or the other. Of course, it's not all positives with liquid biopsies. There are some challenges also associated with them. Here's an image that I have shamelessly stolen from Sesson et al., where they've described that tumor heterogeneity itself can be a downside for liquid biopsy, particularly because of different subclones having potentially different molecular signatures. There can be a decreased sensitivity of the liquid biopsy. Additionally, identifying the appropriate tissue of origin from the analytes that we identify in the blood can be difficult, and there can be differences in terms of the actual detectability based on anatomic factors such as blood-brain barrier, limiting the diffusion of analytes into the systemic circulation. Aside from this, there can be false positives identified with either field defects, which are pre-malignant abnormalities, or age-related clonal hematopoiesis, where we can identify these mutations in a non-malignant hematologic change. Here, Abish et al. Identified that the amount of analyte, particularly in this case, the variant allele frequency, which is a measure of how often a mutant allele is identified as a percentage of the total alleles identified, is directly proportional to the volume of a tumor that we can see either in the lung or elsewhere. This was particularly in lung squamous and adenocarcinomas. And if we look at the bottom here, we can see that a 10 cubic centimeter volume is approximately a 1% VAF identified. Now, we don't typically think of volumes when we're looking at our radiographic. And so in comparison, 10 cc's is approximately a 28 millimeter diameter tumor. So in patients who have smaller primary disease, it is less likely that we'd be able to identify liquid biopsy successfully than in patients with more higher burden of disease. One potential way of improving the sensitivity of these assays is to use a bespoke or tumor-specific assay. And this is where we take the tumor, we identify mutations that are present in that, and use that to design an assay specific for those mutations. This assay can then be used with a lower limit of detection to monitor the patient. Unfortunately, this leads back full circle to requiring taking out the tumor, or at least a sample, prior to being able to analyze it for those mutations that we are looking for. And so it is somewhat putting the cart before the horse. Moving to some potential clinical applications of the liquid biopsy platforms, there's a variety of areas that have been explored, including in early detection and screening of malignancies, in the diagnostic workup of those malignancies, as well as prognostication for treatment response, as well as treatment and disease monitoring. And in the metastatic setting, there's been some identification of potential resistant mechanisms to medications that are being used. We'll explore 3 studies that have looked at some of these. First off, we'll look at the use of circulating tumor DNA in the diagnosis of lung cancers. So this is a single-centered study, an Accelerate clinical trial, which was performed at Princess Margaret, in which 150 patients who had been referred to their lung diagnostic program for investigation and diagnosis, who had previously had radiographic evidence of advanced lung cancer, which they defined as incurable stage 3 or stage 4 lung cancer, underwent both standard investigation as well as a plasma ctDNA test with the intent to identify whether time to treatment decision was shortened by the inclusion of a plasma ctDNA test compared to patients who did not participate in this trial in the prior 12 months and underwent tissue biopsy alone. Looking at this flow, we can see that they had 151 patients initially, 145 of which underwent biopsy, which identified 139 malignancies. Of those, 90 had recommendation for tissue NGS. And when we look down at the bottom, 53 mutations were detected in this population. Interestingly, 35 of them were both in plasma and in tissue. We would expect to see some only in the tissue, but we also identified 11 mutations only detectable in the plasma. Looking at the outcomes from this trial, we can see here on this time to referral to biopsy, results, and treatment initiation, that in the cohort that had both normal tissue biopsy and plasma ctDNA biopsy, there was a significantly shorter time from the referral to the treatment initiation. In that cohort, it was 33 days versus 61 days in the reference cohort. And in a subgroup of the Accelerate cohort, in which treatment was initiated on the basis of ctDNA findings prior to traditional genotyping of the biopsy sample being available, the time to treatment initiation was even shorter. The main areas where this seems to have improved the time to treatment is in both a shorter time between referral and actually obtaining the blood draw versus a tissue biopsy, you can see here, as well as a shorter time from the biopsy to results of molecular testing, seen here. This potentially provides an area where patients who we already know are at high risk for clinical deterioration with advanced lung cancer are potentially able to begin treatment more quickly, and that might provide actually changes in their disease course. Moving to another area of interest is disease prognostication and treatment prognostication. This is a study that came out of the US where they investigated patients who had physician-reported oligometastatic disease and wanted to identify, does ctDNA help stratify patients who are going to respond well to local radiation therapy versus those who would respond less well? This was a multi-institution cohort, initially with about 1,500 patients. However, many of those patients did not have adequate data in regards to either the timing of radiation, the timing of metastatic disease diagnosis, or the timing in terms of when the biopsy was obtained. And so a total of 309 of those patients were known to have metastatic disease prior to radiation and had a liquid biopsy prior to radiation. In those patients, there was a 74% rate of detection of ctDNA prior to radiotherapy. And in those patients who had ctDNA detected, there was a worse both progression-free survival as well as overall survival, with a median PFS of 5.4 months versus 8.8 months in those with no detectable ctDNA, and an overall survival of median of 16.8 months versus 25 months. Additionally, they were able to show that it wasn't just a binary detection versus no detection. The actual burden of ctDNA was also correlated with overall survival. So in those patients who had ctDNA detected, there was also a difference between those who had a low variant allele frequency, so less than 0.1, compared to those who had a high variant allele frequency, which was greater than or equal to 0.1. It was less significant for progression-free survival, but the curves do nicely separate for overall survival. In addition to the actual concentration of ctDNA, they were able to do another analysis for the burden of mutations, both patients who had no variants, 1 to 3 variants, and 4 variants or more identified on liquid biopsy. And so higher burden of mutation does appear to be correlated additionally with worse outcomes. This could potentially help provide more information for us looking into patients who appear to have radiographic oligometastatic non-small cell lung cancer and identify those patients who are potentially most able to benefit from local therapy, from those who potentially may benefit more from subsequent lines of systemic therapy. Next, we'll also talk about a study looking at treatment and disease monitoring. This is a study looking at circulating tumor DNA monitoring during treatment of patients with advanced non-small cell lung cancer. Extra points if you can identify this country, but this is conducted at Zeeland University Hospital in Copenhagen. Again, there were 150 patients with non-curative, locally advanced non-small cell lung cancer that underwent liquid biopsy for cancer-specific mutations during treatment with chemo or immunotherapy, prior to each treatment cycle, as well as during surveillance post-treatment, with the intent to monitor for disease progression. So the actual analysis that they did with these biopsies was either conducted on previously identified mutations, or if there was no standard test available for that, then they designed a patient-specific assay based off the biopsy from the initial diagnosis. So in these patients, a little over half of the patients were able to have a standard assay, and the remainder had either both a designed or both a designed and standard assay or a designed assay alone. And cumulatively, from standard and designed assays, approximately 70% of patients, again, were able to have ctDNA detected. Here we can see some curves showing the change in ctDNA concentration in chemotherapy patients above, immunotherapy or combination therapy patients below, total cohort, patients who had early progressive disease, and patients who had late progressive disease. You can see there's a little bit of noise and a little bit difficult to identify, but when we break these cohorts out, they can then show that both overall survival is correlated with detectability of ctDNA, with a median overall survival difference of 296 versus 578 days, but they were not able to identify a significant difference in progression-free survival, although there is a trend towards significance. Looking at some of the potential patterns of ctDNA in these patients provides some additional information. For example, in this patient, this is a 63-year-old patient who was receiving immunotherapy. She had progressive disease at first first radiographic imaging after 3 treatment cycles. However, her liquid biopsy showed significant ctDNA increase over that same time, prior to even the second cycle of immunotherapy. Another patient, this is a 66-year-old who had immunotherapy as well, showed what was thought to be radiographic progression at first imaging. However, looking at the ctDNA testing, the ctDNA decreased over that time to the limit of detection, and on subsequent radiographic investigation, that previously thought progressive disease was actually shown to be pseudoprogression with a partial response at that time. This 72-year-old patient had chemotherapy, had a partial response after 2 cycles, stable disease at 4 cycles, but eventually showed progressive disease. And we can see from the ctDNA curve that there was initially a good response, followed by a recurrence in the ctDNA and a rise up until progressive disease was radiographically confirmed. Next, this 66-year-old patient had radiographic partial response with a consistent decrease in ctDNA, persistent partial response on radiographic, but continuing increase in the ctDNA with unconfirmed progressive disease initially, followed by confirmed progressive disease. These last 2 patients show something that is fairly consistent in that 15% of surveillance imaging was actually non-conclusive, either with unconfirmed progressive disease, pseudoprogression, or other changes such as a mixed response that were uncertain to the treatment response. In 79% of those scans, there was actually a correspondence between the proximate ctDNA, or the ctDNA measurement prior to that imaging, and the conclusion of subsequent imaging, such as in this case with a rise in ctDNA followed by progressive disease, or in other cases such as a decrease in ctDNA followed by response. Finally, this is a patient who had initially no detectable ctDNA. Throughout treatment, was shown to have stable disease until their ctDNA became detectable and progressive disease was identified at a right adrenal gland. This site was treated with stereotactic radiation with a decrease in the ctDNA back to the limit of detection and continued to have undetectable ctDNA on subsequent follow-up. Finally, this is a subgroup of patients who had immunotherapy and were long-term responders. In this group, you can see initial ctDNA detectable, followed by a rapid decrease to the limit of detection and persistence at that limit of detection moving forward. This one gray curve was from a patient who had suspected clonal hematopoiesis, which again leads back to one of the potential challenges in liquid biopsy, in that there can be detection of mutations unrelated to the disease of consequence. Looking at the time between detection of disease and radiographic detection, we can see here that the progression-free survival is measured from baseline to radiographic progression, with a lead time from the point at which the ctDNA rose. They defined a significant increase in ctDNA as the point at which the 95% confidence interval between two subsequent measurements did not overlap. In these patients, the median positive lead time was 51 days, and in patients with a negative lead time, the median was 16 days. And almost 60% of the patients had a decline in performance status at the time of radiologic progression, which limited their options for second-line treatment. Again, falling back to the thought that earlier detection of disease progression may actually provide more options for subsequent treatment in those patients and potentially alter their disease progression. Lastly, this is a graphic showing the timelines of patients who were receiving treatment when they had hospitalizations, as well as the toxicity from their treatments. If we zoom in on a few of these patients, we can see here the areas that are surrounded by a box near the end of treatment were cycles of treatment that were provided after molecular progression. And some of these have significant adverse events associated with those cycles. So in the cohort entirety, approximately 30% of systemic therapy cycles were given after molecular progression. And they estimated that approximately 75% of patients likely received futile treatment with potential for toxicity from that treatment.
All right, thank you.
Moving on to what we're doing here. As Alex mentioned, we are currently conducting a ctDNA test validation study. Additionally, the BFAST, or Blood First Assay Screening Trial, is enrolling. And also, a new trial recently opened is SABRE Detect. This is our ctDNA validation study. So this is an in-house validation study for all advanced stage lung cancer patients who either have had or will have molecular biomarker testing. They receive a few extra Streck tubes of blood test for ctDNA testing, and these are then tested and compared to biomarker results from their biopsy biomarkers, with the aim to be able to characterize the performance of our in-house ctDNA testing, which will allow for future incorporation. The BFAST, Blood First Assay Screening Trial, this is a multi-institution, large randomized trial where patients with advanced or metastatic non-small cell lung cancer are able to get funded ctDNA testing. The majority of the arms on this trial have already completed enrollment. So if your patient has a mutation other than EGFR exon 20, they would not continue on the trial after their blood ctDNA testing. If they did have that, then they would be continued on cohort F. However, this is an option for patients who might benefit from having ctDNA testing and further evaluation for potential mutational status. And then lastly, our SABRE Detect trial, which is being run both here and in London, is a trial looking at the use of circulating tumor DNA in our early stage patients, which have consistently provided some difficulty in terms of the sensitivity of the ctDNA testing. In this trial, we're trying to see whether testing both pre and post stereotactic radiation can improve the sensitivity of the liquid biopsy, potentially by increasing the concentration of analytes after stereotactic radiation, as well as monitoring these patients for ctDNA changes during follow-up, which may help identify patients who have early disease recurrence, as the evolution from stereotactic radiation changes in the lung can sometimes lead to a lot of those uncertain and equivocal radiographic results. So this study is open to any patient with or without tissue-confirmed biopsy from lung cancer who will be undergoing stereotactic radiation. They require ctDNA samples at their baseline, after the first stereotactic treatment, and then during follow-up. So that's it for what I have prepared. I'd like to open the floor to any questions or any additional discussion in regards to this interesting topic.
Thanks, Thomas, for that really good overview about liquid biopsy. As was mentioned, we're going to be seeing this more and more, and we have it available, at least on clinical trial, for our patients, both from a diagnostics in stage 4, as well as a sort of exploratory analysis in stage 1. And one of the main focuses of our disease site is that we're looking to try to lead the implementation of this alongside our colleagues from laboratory medicine and pathology. So any questions from anyone in the audience or comments? Or I could even invite Ken or Wei from pathology. You guys are, I think, helping out as well with the implementation of this validation study that we have. I think we're hoping for, is it 60 or so samples? And so far we're about a third of the way. Is that correct? Or?
Actually, no. This is way. Yeah, we got 13 actually, so it's 1/5. You know, that's
So 1/5. Yeah.
Yes, yes.
And so, to remind the broader clinical team, the validation study is essentially for patients that have stage 4 non-small cell lung cancer, and they have an existing, particularly if they have an actual mutation or identified target on tissue, or even on, let's say, liquid biopsy from BFAST. We are looking to separately obtain a blood draw as a voluntary basis of seeing and calibrating our own internal processes so that we can come up with the same results. And in order for us to do this, we, of course, need to have our process sorted out before we open up the floodgates, because everyone's going to be asking for liquid biopsies for all sorts of indications, I'm sure, because of the convenience. But that doesn't replace a tissue biopsy. I would think it would be something potentially complementary or in focus indications as liquid biopsy alone. Ken, I'm not sure if you have any other comments to add.
Yeah, so David couldn't attend today, but he wanted us to just sort of pass on the message that we need to increase the rate of rate of samples coming in for the ctDNA validation, basically. So I think, you know, as long as the patient has or will have tissue NGS testing, then we should probably include them, just in the interest of getting the, you know, because right now the speed at which these, like Wei said, we've only received 13, and it's been going on for how long now?
I don't remember the exact date, but I imagine at least 6 or so months, maybe more.
A year, actually. We started to collect the sample last year, actually.
Yeah,
Yeah, so about a year already. Yeah, so it's progressed slowly. Yeah.
that's right. So I will certainly remind so we have, of course, 3 lung medical oncologists on our team. Matthias is also here. He's one of our lung fellows. So Matthias, yourself, and Tatiani, if you guys can also be on the lookout. I think we certainly, I say we, but from the radiation oncology point of view, we certainly could do better. So there are occasionally patients who have NGS testing. They're not available for whatever reason, not eligible for whatever reason for systemic therapy or targeted therapies. And these are individuals I think we could be targeting as well. What I'm thinking, out loud, I'm not sure, Patrick, if you have any other thoughts, but in the CNS clinic, they see a lot of, patients, even with medical oncologists who are outside our institution. And that would also afford another ability to individuals that we treat palliatively or surtatic radiation, but the med oncs are outside. I think that could be another opportunity for us to help with the validation. Because once we have the validation, then we can look to implement this clinically instead of being reliant on clinical trials and other sort of philanthropic or private funding. Because the cost, Ken and Wei, what's the cost for a patient if they wanted, they go get Guardant or Foundation One or whichever? It's my guess would be a couple thousand, right?
At least that. Yeah, I don't know the exact cost. You guys probably know more.
I think Foundation One probably thousands. I don't know exact number, $3,000-4,000 per test. Yeah, for Foundation. Yeah.
And at least process-wise, it's our lung clinical trial team. So correct me if I'm wrong, Vishali, Olivia, and Ilda. I think you guys are helping with this, that if we have an individual who is willing and has been identified to provide a voluntary blood sample so that we can implement or accrue for the validation, that you guys are helping with this, I believe.
Yep, that's correct.
Great. Any other questions or comments from the group?
I was just going to say that's an excellent presentation, Thomas. But I was trying to wrap my head around with some of the data and looking at, you have patients who you showed responded to immunotherapy, or what they're going through immunotherapy, and you're looking at this biomarker, which we don't have any target for, like TP53 and the KRAS 12V. What does it mean? Because we don't have a target for it, and yet patients are on some form of therapy. And if that biomarker is rising or falling, what does it mean?
Yeah, so I think even though we're not directly targeting those mutations are representative of the burden of mutant cells in the patient's system. And so by tracking those mutations, we're actually able to get a better identification of the burden of cancer remaining in the patient, even if we're not actually targeting those cells with a therapy. Those are just a marker of mutant DNA in circulation, which is coming from malignant cells.
So then could it also mean that whatever therapy you're using, it may actually be working at other areas, but except for the active biomarker, which is theoretically not responding or responsive to your current therapy?
Definitely. So there's definitely, particularly in assays where you can see multiple markers being tested simultaneously, sometimes you could see certain mutations decreasing in terms of frequency, whereas other ones are persistent or increasing, which may be representative of subclonal populations, some of which are being appropriately treated by the current therapy that they are receiving, and some of which may be more resistant subclones requiring a separate treatment or a more targeted change in treatment to assess those or target those.
And then if I could just ask one more question, because you also showed the implication of following the ctDNA and looking at disease-free survival. It sort of reminds me of screening. When screening came on, then you have sort of like a lead time bias. So is there a similar concern that because we don't really have good controlled data, and then are we seeing some of the benefit is due to a lead time bias in terms of disease-free survival or even overall survival?
So primarily in those studies, the analysis was done based on radiographic progression. So the duration of progression-free survival was analyzed on the same level. I think the differences we're seeing is in that the actual populations that we're seeing in patients who have detectable ctDNA versus those who do not have detectable ctDNA is actually just a difference in the burden of metastatic disease between those patients, and that particularly those who have higher level of ctDNA likely have a higher level of either subclinical or radiographically occult metastatic disease that we just could not appreciate previously.
Thank you.
Yeah, Yi, I think you bring up a really good point in that if we change the goalposts of, when recurrence or diagnosis is, does it actually result in an actual change in the overall sort of outlook for the patient? The one thing, at least with the downtown study, is that the complementary aspect of getting the liquid biopsy and the tissue biopsy and initiation of treatment, at least as an endpoint, that probably is a big value add for our patients when they know that they have cancer, and then it takes another 2 weeks to finalize, well, do I have a cancer that I treat with a pill? Do I have a cancer that I treat with chemo? Or do I have a cancer do I treat with immunotherapy? And even if those 2 weeks may not necessarily impact, even though it does sometimes, the overall, let's say, survival of the patient, it typically is a very agonizing 2 weeks. And so having as much information as possible, I think, helps us as the treatment providers to give timely advice of what we'd like to do. So we will make a very concerted effort to get as many samples as possible, as quickly as possible. I know it's been slow, but I think, Thomas, your choice of topic was very timely and fortuitous for us to, because it's been brought to our attention that the validation has been going slower than what we anticipated. We have the team that's very motivated. We just need to get the samples.
And another suggestion that David had, I'm not sure if he might have emailed already this, but he mentioned that our June and the Brain Mets RAD group may have quite a few patients with metastatic lung cancer and previous biomarker results. And could we tap into those patients to get more samples for the validation?
Yeah, so that's a great idea. So I'll get a thread between Arjun and David, just so that the CNS team is aware. They probably treat the most actionable mutation patients who are sort of not presently being approached for this validation. So I think that that would be a very sensible group. And also, it's on a different day than our lung clinic, so that won't overburden our trials team necessarily. So those are on Wednesdays when they have their clinic typically.
And there's a question in the chat. Can we screen patients who are awaiting tissue biomarker results? I think absolutely, right? Yeah.
Yeah, absolutely.
Yeah.
That's a good idea, Ilda. Thanks for that. Okay, so I'd like to thank everyone for their attention, for our pharmaceutical sponsors, for lunch as always, and for us to meet in this forum. And stay tuned about messaging on the next set of topics. We do these rounds once a month for education purposes. Thank you.